My name is Roland Schmieder, University of Erlangen in Germany. I will show you our results, our post-hoc analysis, and I will start with the fact which you are all aware that empiric outcome have shown us that SGLT2 empagliflozin improves cardiovascular renal prognosis. In the first attempt, we thought about to look at vascular function, and I think this is intriguing because the vascular function is a common denominator for the improvement in heart failure as well as in renal failure. The reason for that is, if you look at the pulse curve, usually we found a very nice pulse curve, but in patients with diabetes, and the older they are getting, we find an augmentation of the systolic blood pressure. That's due to a faster reflection of the pulse wave and the decrease in diastolic blood pressure. Now, this sounds not so bad, but at the end, we have an increase in afterload, thereby increasing the burden to the left ventricle. And we have a higher pulsatile component going into the interglomerular beds, thereby damaging the glomerular endothelial cells. So this is a common denominator. And we aimed at analyzing these after treatment with empagliflozin for 6 weeks. In a double-blind study, crossover study, everybody was his own control. And this has been published in Circulation 2017, where we found the following. Let's focus on the most important one, the central pulse pressure. It reduced significantly compared to placebo after 6 weeks. Also, 2 other parameters which can derive from the pulse wave, a little bit more advanced parameters, forward and reflected wave amplitude, did also have been found to decrease, as well as central systolic blood pressure. Now, that's a lab with a new technology. You are also able to measure these vascular parameters under 24-hour ambulatory conditions, and we found a similar pattern. So this has been published. Now, with all these attempts to explain the empiric outcome trial, we thought we go back to our data and analyze how does empagliflozin improves arterial stiffness. What is the factor for that? What's behind that? We know all these various factors that have been discussed in several reviews by several authors. Now, in our study, we have several parameters assessed. We assess the volume status by the hematocrit, of course, but also by copeptin, an ADA parameter ADH parameter to measure the volume status. Of course, glucose metabolism, lipid metabolism, uric acid, sympathy activity. The only parameter, I'm sorry for that, we checked heart rate. We have no microneurographic data, which would be, of course, very nice to have. Blood pressure, and we measured inflammation with a high sensitive CRP. In 58 male patients, we did this multivariate analysis. These were all patients free of any clinical signs of infection. That's important. They have been excluded. Now, make a long story short, all this is a multivariate analysis. What at the end turned out was that in addition to 24-hour systolic blood pressure and age, I think this is very good understandable that these have effect on vascular function. Change in high sensitive CRP turned up independently of the other factors in the change of this improvement by empagliflozin, which was placebo-corrected. So this is a signal, we think, which is very important. We did 2 ways, one with HbA1c, one with the fasting blood glucose as a parameter for the metabolic or for the glucose control, and it turned out in the same way. And simply then, if you look at the achieved values of hCRP, and here the central pulse pressure, or the other one, the forward or the reflected wave amplitude, we found also a correlation. And I think from these results, we open a new field which has not been analyzed, in my opinion, in clinical terms, experimentally well, very well, but not in clinical terms, whether we have an effect of the SGLT2 inhibitor on inflammatory signals. And I think this would be, at least to some extent, explain the beneficial vascular effects and thereby potentially other effects on the real outcome. Thank you very much.